Hey everyone, in this talk we're going to cover radiation dose monitoring of occupationally exposed staff at Monash Health. Before we jump into the talk, I'd like to warn you that this presentation contains images of people who have experienced radiation-induced tissue effects. This talk is made for any staff, contractors and volunteers who may be exposed to ionizing radiation as part of their work. We will be covering some basics of radiation safety, dose monitoring, dose limits, considerations around pregnancy, and responses to radiation incidents. So let's start with some motivation. Why should you care about radiation safety? Well, first, because you want to protect your eyes. These are radiation-induced cataracts, specifically posterior subcapsular cataracts, which are the classic pattern caused by ionizing radiation. The images come from a study on patients treated with a very high-dose plaque brachytherapy for alveolar melanoma. But the intro of that paper makes an important point for us. The lens is the most radiosensitive structure in the eye, and cataracts can develop at doses as low as half a gray. In fact, the incidence of post-radiation therapy cataracts ranges from 45 to 100%. And that threshold is definitely reachable in an interventional career if staff don't use shielding consistently. Radiation damages the dividing cells in the anterior lens. Those cells migrate backwards and accumulate, and you end up with these PSC cataracts. They're not age-related, they're not reversible, but they are preventable. So even though these images come from a therapeutic context, they're a very real reminder of what radiation exposure can lead to if we skip the basics of radiation safety. Second, radiation safety is important because you want to protect your limbs. The images here are of an industrial technician who accidentally exposed his hands to around 50-60 gray, as well as his whole body receiving 6 gray, which is typically lethal. He developed immediate erythema, and by day 10, the inflammation, edema, and blistering had returned and kept progressing. Over the following weeks, he went through the full spectrum of tissue injury: epilation, desquamation, deep tissue necrosis, and severe pain, despite intensive care. He ended up requiring 11 surgeries over nearly 2 years, and surgeons later said that amputation early on would have actually reduced his pain and hospital time. The only reason he survived the whole body dose is because he happened to have an identical twin who could donate bone marrow. How extraordinary. Now, this kind of exposure is not what we see in modern diagnostic imaging, but why is that? Because of radiation safety and protection. Finally, across a lifetime, the major causes of cancer are things like smoking, diet, infections, and other lifestyle factors. These make up the bulk of cancer cases. Radiation is only a small contributor, but it is one that we can to some extent control. The graph shows cumulative dose on the horizontal axis and the estimated resulting increase in risk of cancer death across a lifetime. Now, even at 100 millisieverts, which is far above what any properly monitored healthcare worker should reach, the increase in lifetime cancer is in the range of about 0.5%. Our job is to make sure staff never accumulate unnecessary dose. Through best radiation safety practice, we keep exposures well below these levels, and we keep cancer risk due to radiation negligible. Understanding the different radiation risks is one of the most important concepts in radiation safety. The difference between stochastic effects and tissue effects. Stochastic effects, like cancer, have no threshold. The risk is small at low doses, but increases with cumulative exposure. The severity doesn't change, only the probability does. That's why even small, repeated exposures matter over the length of a career. Tissue effects, on the other hand, do have thresholds. Once you cross that threshold, you get cell death, resulting in things like skin erythema, desquamation, necrosis, cataracts, or infertility. Once the threshold is exceeded, severity climbs rapidly. The key point for staff is, most of what we are worried about day to day in diagnostic imaging is stochastic risk, just keeping lifetime dose as low as reasonably achievable. But in fluoroscopy and interventional work, hands, skin, and the lens of the eyes can approach tissue effect thresholds if shielding and technique are not used properly. So understanding these two categories helps us tailor protection and monitoring to the risks that staff face. This slide shows the three main places where staff are exposed to radiation in the workplace. On the left, in interventional radiology, most dose comes from scattered radiation coming off the patient. Primary beam exposure should not happen unless the extremities encroach into the field, but scatter can still be significant, especially for hands and eyes if shielding and distance are not used properly. In the middle, CT fluoroscopy is similar. The operator stands close to the gantry, so even though exposures are short, the combination of scatter and repeated procedures adds up over time. On the right, nuclear medicine and radiopharmaceutical preparation mainly involve gamma radiation from unsealed sources, which is a different exposure pattern. It's constant, usually of higher energies, so more penetrating, and thus requires good time-distance shielding habits. These are the environments where proper monitoring, technique, and PPE make the biggest difference to staff dose. So which staff are monitored? Well, staff are monitored when there's a realistic chance that they could exceed the public dose limit of 1 millisievert per year. So monitoring is not for everyone. It's targeted to the people whose work can actually put them at risk. These groups are chosen by the Radiation Safety Committee based on things like how often they're exposed, the type of radiation involved, how long they spend near radiation, and the potential for accidental high-dose events. The image on the right shows all the possible monitoring points for higher risk roles: whole body, lens, ring, and wrist badges. For context, this photo comes from a study of staff handling gallium-68 Dotatalk, a relatively new tracer at the time of publication, where they used these monitors to measure exposure during radiopharmaceutical preparation and injection. Our goal is simply to identify who could realistically accumulate dose and ensure that they're properly monitored. This slide shows who needs radiation monitoring at Monash Health. Essentially, anyone likely to exceed 1 millisievert per year is placed on the monitored list. Interventional staff, so radiologists, cardiologists, vascular surgeons, and scrub and scout nurses are monitored because their work involves regular scatter exposure. They typically need whole body and lens badges, with extremity badges optionally added when hands are close to the beam. For medical imaging technologists who work permanently in angiography, whole body monitoring is also required. The key point is that dose monitoring is purely risk-based. It depends on the role and the likelihood of significant exposure to radiation. This is the standard whole body badge we use to measure a staff member's overall exposure. It's worn on the torso, between the chest and the waist, and importantly, underneath the lead apron. The embossed side should face outward so the detector is oriented correctly. These badges must be worn on site only and not taken to other hospitals because they can create inaccurate readings. They're changed every quarter or monthly for higher risk groups, so returning them on time is essential for proper monitoring. You can also see some information on the badge, which includes the badge holder's name, the organization, and the monitoring period this badge corresponds to. Lens badges measure radiation dose to the lens of the eye, which is one of the most radiosensitive tissues. They need to be worn as close to the eye as possible, sitting inside or behind your protective eyewear, so they measure the dose that actually reaches the lens. They're required for high scatter work like interventional radiology, cardiology, vascular procedures, and CT fluoroscopy. The images here show two setups behind lead glasses or under a full-face visor. Ring dosimeters measure dose to the hands and fingers, which can be highly relevant in certain tasks. They should be worn on the index or middle finger with the detector facing inwards, so pointing towards you when you look at the palm of your hand. Staff that are issued a ring dosimeter must wear it when reconstituting, dispensing, or administering radiopharmaceuticals. Fetal dosimeters are issued after a pregnancy declaration to monitor the dose to the unborn child. They're worn at waist height, ideally at the front midline, and must be worn any time the staff member is on site. Importantly, the fetal badge is worn underneath any lead apron, so it measures the dose actually reaching the abdomen. But we will come back to pregnancy considerations a bit later on. Electronic dosimeters give real-time dose readings, so they're useful in situations where exposure might temporarily increase. For example, contractors, ED staff handling radioactive patients, or clinicians who aren't routinely monitored. They're worn close to the torso or pelvis to estimate whole body dose, and after each use, the cumulative reading needs to be recorded in the relevant logbook. These are the dose limits we work to in Australia. The whole body and eye lens limits are both 20 millisievert per year, averaged over 5 years, with no single year allowed to exceed 50 millisieverts. Hands and skin have a much higher threshold of 500 millisievert per year, reflecting their higher thresholds. For pregnancy, the limit is much tighter, which is 1 millisievert for the remainder of the pregnancy once declared. These are our local investigational levels, triggers for the medical physics team to review a staff member's dose. They're set well below regulatory limits, so we can pick up any unusual exposure early. For example, nuclear medicine technologists have a tighter whole body trigger at 0.5 millisievert per month, while most other staff have 1 millisievert per quarter. Lens, ring, and fetal badges have their own thresholds too. If someone exceeds any of these levels, we simply investigate their work practices to make sure that everything is safe and compliant. This slide shows the core PPE used to reduce scatter exposure in fluoroscopy. The lead apron, thyroid shield, lead glasses, and the ceiling suspended and table mounted shields. All of these work together. The apron and thyroid shield protect the torso and thyroid, the glasses protect the lens, and the ceiling and table shields block a huge amount of scatter before it even reaches you. According to Australian regulation, PPE needs to have at least 0.25 to 0.5 mils lead thickness equivalents at 150 kilovolts. This diagram highlights how each shield reduces the scatter field around the operator. Two of the simplest and most effective ways to reduce dose are distance and time. If you double your distance from the radiation source, your exposure drops by a factor of 4. That's the inverse square law. And the less time you spend near the source, the lower your dose, because exposure falls with time. Changes in your distance from a source or how long you're in a room can make a big difference to your dose. Positioning makes a huge difference to dose. If you keep your hands out of the primary beam and whenever possible, stand on the detector side where scatter is much lower. Use pulsed fluoroscopy and lower frame rates when appropriate, and always try to stay behind a shield. Whether it's the ceiling suspended shield, table drapes, or even another staff member that is already protected, the diagrams here show how dramatically scatter drops when you are standing behind shielding. When a staff member declares a pregnancy, we follow this pathway. First, the declaration is made confidentially. The medical physicist or RSO then performs a dose assessment. If there's any chance the projected dose could approach the limit, duties are modified. Otherwise, we issue a fetal badge for monthly monitoring. The figures on the right help put this in context. The regulatory limit is 1 millisievert for the entire pregnancy, and typical under-lead doses for interventional work are well below that. The goal is simply to ensure the pregnancy is managed safely while supporting the staff member in their duties. An investigation is triggered whenever something looks unusual in someone's dose record. That includes readings above our investigational limits, badges that are late or missing, a sudden jump compared to previous quarters, or a dose much higher than others doing the same work. The investigation is not about blame or punitive measures, it's simply to check whether the badge was worn correctly and whether there's anything in the work practice that needs adjusting to keep our staff safe. When we investigate an unusual dose, we start by reviewing the person's work practices and PPE to make sure everything aligns with radiation safety principles. We then look at whether the high reading happened while the badge was worn, for example, if someone had a medical scan while still wearing it, or whether it was exposed when not worn, such as being left in a room during imaging. We also check the workplace layout to rule out exposure from neighbouring areas. Finally, we document everything and present our findings to the Radiation Safety Committee. Most high or unusual readings come from simple badge mishandling, so these steps prevent almost all incidents. Always remove your badge before personal imaging, and don't leave it in any imaging room. Keep it away from radiation fields when you're not wearing it, and only use the badge issued to you. Wear it correctly, under your PPE and in the right position, always when you're at work, and definitely don't send it through the washing machine. Badges need to be returned on time because they're recycled. If they're late, they get marked as lost and there's a replacement fee. More importantly, we can't monitor your dose without those results, which delays RSC reviews and compromises your radiation safety. So timely badge returns are essential for accurate monitoring and compliance. Towards the end of each monitoring period, you'll get an email letting you know the new badges have arrived. When that happens, return your current badge to the old TLDs box, pick up your new one, and record the changeover in the logbook. Start using the new badge straight away, and if you've lost your badge at any point, just contact your site's TLD coordinator or the RSO so we can organise a replacement. To wrap up, the main messages are simple. Wear your badge correctly every single shift and keep your dose as low as reasonably achievable by using PPE, distance, and good practice. Let us know early about pregnancy so we can support you, and contact the RSO or medical physics team if anything unusual happens with your badge or you are concerned about a high exposure. Finally, return badges on time. Your role is essential in keeping both yourself and everyone around you protected. We are all responsible for radiation safety. Thank you for listening, and if you have any questions, please get in touch.